Well, kia ora koutou. Welcome again. This is the second of two consecutive webinars, and I'm guessing that quite a few of you attended last night, so welcome back. The second of two consecutive webinars provided by the Southern Wound Healing Group in collaboration with the New Zealand Wound Care Society, Mobile Health and the University of Otago. Tonight we have two presentations separated by a short break and followed by a panel discussion where the speakers will respond to your questions that you log during the evening. Please do log those questions using that Q&A function. And remember, you can upvote other people's questions by clicking on the speech bubble alongside that question if you want to prioritise it. You can also use your chat function to introduce yourselves. Please just set it to all panellists and attendees. And we're going to show a couple of videos from our sponsors. Can we have the thank you slide up? First of all, there we go. A big thank you to all our sponsors. And when Emil is ready, we will show those two videos.
It's as simple as it seems, the twinkle in your eyes, the way that time slows down when you kiss me as we fall asleep in a bed of butterflies. Just close your eyes and then you'll see it. You don't ever have to look too far. You don't have to cover up your scars. You're perfect, darling, just the way you are. So before you think to rip yourself apart, open up my heart and you'll find love, 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 love.
Chronic wounds and skin conditions can take a long time to heal, and for patients, this process can be painful, expensive, and uncertain. Still today, many hospitals and healthcare providers use manual methods to measure a range of skin conditions. Patients often have many care providers over their healing journey. Inconsistencies and inaccuracies can appear in the patient's record, making it difficult to accurately track the healing progress. Paper records are also easily lost or unavailable during an assessment. There's a better way. Silhouette is a digital solution that allows care providers to effectively assess and manage wounds without inconveniencing their patients. The easy-to-use system captures images and records precise 3D measurements, including depth and volume. Any care provider can carry out the assessment, and the results will be accurate and consistent. Images and notes can also be captured using a range of mobile devices with Silhouette Lite Plus and Silhouette Lite. The data collected at the point of care is securely stored in a Silhouette central database and can be easily shared across different locations. The centralized database enables all care providers to monitor how treatments are working and make timely adjustments to care plans if necessary. Patients engage with their healing progress when they can follow the data in Silhouette. Silhouette improves patient outcomes for our clinical practice and research customers across more than 50 countries.
And now it's my pleasure to introduce your first speaker for this evening, Emil Schmidt. Emil is a wound care specialist at Dunedin Hospital, where he is responsible for the selection and evaluation of wound products and technology. And his topic tonight is compression systems. And you can see him there sitting behind a multitude of equipment that I'm sure he's going to share with you. Welcome, Emil.
Kia ora, everyone. Welcome to New Zealand. And good evening and so much. So thank you for your interest for tonight. And hopefully you were able to also watch the webinars from last night. We will pick up on a few points from last night. Rebecca sits beside me. She will present after myself, and then we have a Q&A session afterwards. So, so we talk about compression systems today, and especially for lower leg edema. Before I want to talk about this, I want to bring your attention to our National Wound Conference this year, the New Zealand Wound Care Society, which I will refer to several times during the talk. The Wound Care Society does every 2 years national conferences, and it's a pleasure to tell you that we have the conference this year in Hamilton. The title is Navigating the Currents in Wound Care, and I put the slides up here. We got fantastic keynote speakers from plastics and reconstructive surgeons to trauma surgeons, and also nurse practitioner and community, and other very well-known invited speakers for the conference. Particularly this year, we're going to have a specialty debridement workshop because it's always successful. This year, we're going to do a whole morning on the 9th of September for just concentrating on debridement workshops. So the link is here to get more information. The abstract submissions are now open, and please meet us all in Hamilton for a wonderful conference once again. So now we're going to go on to the compression systems. A little bit what I'm going to talk about it today is here. Just basically, I won't read all the slides off. The idea of the slides is so you can have a resource when you want to go back and have a look later on. Okay, so there's much more text on the slides, but I won't read them off. It's really good to have local and international resources when you talk about compression systems and compression management. I'm going to put 3 up here, which I use throughout the presentation. The first one is one of the best guidelines really around the world still, which is evidence-based, is the Australasian New Zealand Clinical Practice Guideline for the prevention and management of venous leg ulcers from 2011. And they're currently just being reviewed in the last year, and hopefully within the next 2 or 3 years, they will be updated. The New Zealand Wound Care Society and the Australian Wound Management Association work together in updating the evidence since 2011. There's a really good document here, which I also used, is called STRIDE. It's a professional guide to compression garment selection for the lower extremity. It's from 2019. The guru really under compression bandaging is Professor Hugo Parch, which wrote a foreword to that guideline too. It's a very practical approach, which bridges the practical stuff in the theory. So I would recommend those. Those 2 guidelines are all freely available on the websites. And then I go to local guidelines like the health pathways, which is the Southern DHB one. And I'm sure around the country you have got similar pathways for managing venous disease. Just a few words about venous system efficiency. The vast majority of lower leg wounds and lower leg ulcers are either venous or venous mixed ulcers, about 75 to 80%. And those venous leg ulcers are primarily a result of the chronic venous hypertension. So basically because the valve is incompetent, and it resides in a venous stasis and edema. So basically what you got is an outlet problem. The fluid goes in, the blood goes in, but it doesn't get returned to the upper body because of the valves which are leaking. And you can see here on the diagram on the left, which is enormous venous flow. You can see it right in the muscle, the deep vein, which you can't see, and then the superficial vein, which you can see on the skin. And they're connected to the perforator veins. So if the valves are all working well, it all goes into one direction. If the valves are leaking through the perforator vein, which is within the muscle, and then goes through the muscle to the superficial vein, if they're leaking, you get a turbulence and you get a backflow. And you also develop edema over time, which again is shown in this diagram here on the left, which shows a leaking valve in the vein, and underneath there's this turbulence of blood, And within time, and because of the venous hypertension, of the high pressure within the vein distends basically like a balloon, basically, which is an aneurysm, and it gets weak. And then that you can see then as a varicose vein or varicosity. It's a thinning and stretching of the vein. And you can see that on the skin and through assessment. Why do we get venous insufficiency? Often it's blood clots, DVT, thrombosis, varicose veins, or obesity, and so forth. Family history is quite important, or if you sit or stand for long periods of time without moving. And you can see those changes in the leak, and I'm going to talk about that now a bit more. These changes in the leak, and it's not part of the discussion today in more detail, but these changes are long-term changes due to venous hypertension without treatment. And you can see on the top left, which is an ankle flare, there's small venules which show some hypertension there. So hemosiderin changes, those browny colors on the second to left one here. Through the right one, which is the lipodermatosclerosis, there's hardening of the skin. But you can see it just looks unhealthy through the pitting edema and also the atrophy blanche on the bottom right. And that leads over time, or can lead to skin damage and also to venous ulcers. Not everybody who has long-term hypertension will get ulcers, but about 1.5% to 4% will develop venous leg ulcers. Like I said, those changes are long-term changes. They won't happen overnight. Those will take many years to develop those. So that's enough about venous insufficiency. Now think about the importance of compression therapy. And that's our talk for today. It has been shown again and again that compression increases also healing rates compared with no compression. And this data from the Cochrane Library from 2012 was done basically a systematic review, and that was the conclusion of the data search. Now, is it applied in practice? We've done a retrospective study of 40 patients in 2012, where we looked where patients came to the clinics, so vascular clinic from the community, and we showed that on a very small number of patients were in compression bandaging or in any form of compression, about 3% in compression bandaging, and 22% initiated compression therapy in the community. And there was a low confidence in assessing appropriateness for example, ABPIs and how to apply compression bandaging. And as a result, the patients may not always receive the full benefits of the treatment, obviously. So when patients were sent out after the assessment in the vascular clinic, the vast majority, up to 80%, had any form of compression applied. So we know that compression works. Why does it work? Because it assists in the management of edema, so it reduces the edema, it prevents and treats venous leg ulcers, it improves the venous and lymphatic function, and also the nutritional changes is improved in the skin. So it reduces the risk of developing this long-term changes if you initiate compression therapy early enough, like we talked earlier on in those pictures. And also improves dramatically the clinical outcomes for patients. So if often when they come to the clinic for the first time, they feel heavy leaks, they have itching skin, the venous eczema, it's painful because they're so heavy, they can hardly walk, and it has a huge effect on quality of life. There are many, many studies done how it affects quality of life when you have venous disease. There's a good principle is the higher the compression, the better the healing rates. So what we ask right at the beginning is that we like you to refer early. So if you're uncertain about any treatment, really, we really encourage people to refer to wound specialists or to the nurse practitioner like Rebecca in our service, so we can get you assistance and get help as soon as possible. These days are many different ways of getting advice. You ring up, call us, send an email, texting, photo, or you use ERMS referrals on Health Connect South, and then we will respond. So here I've got to start with a patient, I call her Jenny, and she will tell her story in herself.
So I had knee surgery in November 2019. The knee surgery itself went fine. I had a wound on my upper right calf, which never really healed properly. And it's been 9 months of ongoing kind of disasters with it. I had negative pressure vac dressing for, I think it was about 2 months, and that didn't really do anything. And so I was eventually referred to the wound specialist, and he put me in compression dressing, and I've been in that now for 3 weeks. And in the 3 weeks that I've been having compression dressing changed 3 times a week, it's gotten 80% smaller.
So here you can see, and I think if you saw the Silhouette advertisement, the video, this is one of the Silhouette graphs. So this is the digital documentation system we have available, and we use it a lot for educational purposes. And it's really great to see here how it changed, how the wound changed over time within a relatively short period of time once compression bandaging was initiated. So as I said, I will go back to those guidelines because they're freely available and they're evidence-based, and I really encourage you to use them as you can. So I'll show you this flowchart here. I love the way those guidelines use flowcharts. I love flowchart because we're all busy and we don't have time to read through 150 pages. So those flowcharts are very useful. So here we are. There's a whole first page of assessing a patient with venous leg ulcers. I won't go through this, of course, but I will just show you in terms of the ABPI, so the ankle pressure index, and how it then refers to how to treat next. So those, for example, ABPI on between 0.8 and 1.2, if it's an atypical or arterial characteristics in your previous assessment, you refer to a specialist and so forth. If it's between 0.8 and 1.2, or got characteristics of venous etiology, like I show you CEAP classification, then you instigate management of those venous leg ulcers, which is basically the next page. So here's the next page. So another flow chart. So you got 2 flow charts. Okay, first the assessment, then is the management. All right. I only concentrate on the compression because that's our topic for tonight. So then you go into graduated compression therapy in the absence of arterial disease or diabetes. Aim for 30 millimeters or higher elastic or higher stiffness system. We're going to talk about that because I think that's quite important to understand it in principle. So this is the management. Should be monitored closely, obviously, and so forth. Now, the next also is step will be once it's healed, prevention is really important. So that's why we often say patients need to go into compression, and they always ask me for how long, and they ask Rebecca the same thing, and Tria, whatever. They always ask it, what's our answer is usually, for the rest of their life. And then, they're 85 years old, and say only for the next 50 years or so, that's fine, okay? So it is really a lifelong commitment to wear compression therapy. We have patients who have been in compression stockings for 40, 50 years. And they come very, they're in the 70s, 80s now, and they've done really, really well in preventing skin breakdown. If you wear compression stockings, then you reduce the recurrence rate by 70% of venous leg ulcers. So it makes a huge difference. So these are the oscillation guidelines, and the other ones I wanted to briefly point out, so that's where you can find help, is Southern DHB Health Pathways. So, and you might have pathways in around New Zealand that look similar, I hope, where you go into treatment for varicose veins and chronic venous insufficiency. And then it talks about management, and then it talks about compression therapy for varicose veins. So these I try to really align what I'm talking tonight with those guidelines, both of those guidelines. Now, yesterday we talked about doing ABPI. We demonstrated it on ABPI. Briefly, I talk about it again. So you got a handheld vascular scanner. On the top picture here, you take brachial blood pressure on both arms, okay, and then you take the highest one. Then you go to the lower limb, and then you do the same, you do the blood pressure on the lower limb. So you listen to the posterior tibia and to the dorsalis pedis, so 2 arteries, all right? And then you really get the highest of those twos and divide the leg over the arm, and then you get an index, all right? It's an arterial test we do. And so people, when we teach, get a bit confused about this because we talk a lot about venous disease, but here we're checking the arterial blood flow. The reason we do it is to make sure that when we apply compression systems, they are safe to apply. So we're checking the arterial blood flow. This is quite a good slide, I think. It stood the test of time because that shows you the relationship between ABPI and the level of compression. So we sort of say between 0.8 and 1.2 in the absence of diabetes or any arterial disease, any arterial characteristics, it's a normal ABPI. So for normal ABPI, we assume it's a venous disease, it's a venous ulcer, and then you can see the pressure on the left arrow. The pressure goes from 20, 40, 60, all right, so we can use high compression. And then the lower we go towards 0.6, 0.5 would be a mixed, and towards the right, it would be more arterial. So obviously, the lower the ABPI is, the higher the risk of compression bandaging, and we need to basically adjust our level of compressions. Here are the community health pathways numbers. They're all pretty similar. Don't get, like Sarah said yesterday, don't get too hung about it if it's 0.8 or 0.9. It's more about how does it fit into your whole assessment. And again, I want to put a plug in for our workshops here. We're gonna run assessment ABPI workshops on the 22nd of April from 12 to 2 at Dunedin Hospital. So you have to be being able to come to Dunedin Hospital. Like we said yesterday, we do also teaching and workshops around the Otago district or the Southern DHB district, and that has worked quite well. But you have to register for this. You have to you need to email Ruth Mullinger on at otago.ac.nz and register. And then we will send you out a workbook, a bit of your questionnaires, not too heartbreaking. Okay, and then you come and we have a good time and assess and do ABIs practicing. So, what is it defining the ideal compression therapy system? Well, there aren't really one ideal compression system. They all have slight advantages, slight disadvantages. Most of the systems now incorporate inelastic components, and we talk about this in a minute. They should be comfortable. They should be producing a good anatomical fit. They should be allowing functionality and movement. So basically, when you move your ankle, you should be able to move it freely. should be comfortable at rest, and it should be easy to apply and adopt a range of limb sizes and shapes. So that's really important. It shouldn't be too complicated, because then the risk of mistakes increased. So it should be easy to apply. And of course, it should be durable and not too expensive. And people shouldn't have too many allergies towards it. One word about graduated compression, because that is really important, because what we talk about is we apply graduated compression. So the compression will always be higher at the ankle and lower towards the knee. And as you can see in this diagram, the ankle is smaller, and therefore the pressure will be higher when you apply it toward, and then it goes lower towards the knee. So graduated compression. Now, we're coming to classifications. Again, it's quite confusing, to be honest, but I will keep it as simple as possible, and hopefully it will make sense. So there are no worldwide standards in terms of one classification system. There are different ones: British, French, German. I keep the German standard because it's closest aligned to the standard we use in our practice and around New Zealand in the Australasian guidelines. The testing method, and then we goes in class 1 to class 4. So class 1 will be 18 to 21, class 2, 23 to 32, and class 3, 34 to 46 millimeters of mercury, and class 4 even higher. So when we talk about the pressure is measured at the lower calf muscle, call it the B1 site. So that's where it's measured by the companies who produce that stuff. Okay, it's also measured when we do research on it. So it's actually at the beginning of the calf muscle when we measure the pressure with pressure transducers. So these numbers are measured at the lower gaiter area. Yeah, we need to talk about stiffness. So compression dosage, like the pressure, is not the only variable which we apply when we talk about compression systems. The dosage describes the pressure which is applied, like you can see here, that machine which actually has got a transducer, and that's how we check the pressure and teach and also do research with it. This is the dosage, okay? But also the stiffness or the elasticity of the textile we use is having an impact on how compression is applied. And that will become more clear in a minute. So finally, let's talk about compression systems. And we start with talking about single component bandages, elastic ones, and non-elastic, multi-component and non-elastic bandages. And then we go on to multi-component bandaging systems. One word here now. So we brought everything in here, what we use in our practice in terms of compression hosiery. I've got no time to show you all those. I thought the best way, listen please, the best way would be if you have, we can show you during the question and answer time some systems you want to see. So the best thing would be if you write in your question, could you please show us the elastic bandage system, for example, or the Coben system, all right? And then we spend a minute or two on this. Okay, so I keep just talking when you ask us what you want to see. Is that a deal? Good. Okay, so the bandage system is usually applied either class 2 or class 3. Okay, so class 2 or class 3. Before we talk about that, we have some key principles, okay, when you apply bandages. And I won't go into much detail. This is one of the slides which I will not read out, okay? Because applying compression bandaging, you need to do competency. It's really important that you apply, that you understand how to apply it and practice it with somebody who has done the competency before, because you can do damage if you don't apply correctly. Therefore, the bandaging should be applied by a trained health professional, okay, either through according the manufacturer's guidelines or through local compression bandaging competencies. And I just show you our competency bandaging study days, which we do. So we're running one every month. And again, you're going to be filling a workbook, and do some pre-work, and then come all primed up and ready to go. We go through theory and practice again, and then we have practice and bandage until we feel comfortable. And then you go out there as a beginning practitioner with compression bandaging competency. Because as I see, then these are just some slides of when you apply compression bandaging incorrectly, can cause a lot of damage. Here we are, bandage system. So here is a long stretch bandage, okay, class 3. It's a long stretch, so that means, and I'll show you that one now. If you listen, watch me. Long stretch, it's applied, it's got a long stretch. See that? Ooh, where is it? Here, long stretch, okay, long stretch. Thank you, Billy. Billy is our IT guy. I asked him to show me back now, right? So Billy, great, okay, so he's a long stretch. This is the only bandage which gets applied 50%, all right? This bandage system has some rectangles here. So if you stretch it, it becomes a quadrant or a square, all right? Then you apply the correct stretch, all right? And it needs to apply 50% overlap, all right? And then you got nice, even pressure. Not like this, okay, or stretch it, so always the same pressure. Don't worry about it, you will learn it when you go to one of the study days. The bandage system, because it's like basically a stretched rubber band, it's more flexible. Okay, if you see the pressure mapping here, so this elastic bandage, when you walk with an elastic bandage, it sort of gives away and presses against a little bit against the calf muscle. All right, because it's got a high resting pressure, rubber band is basically need to be really cautious when you got some arterial involvement in your leg ulcers, okay, and or your edema, because a high resting pressure day and night, needs to be applied every 24 hours. So elastic, and then the other one is the inelastic pressure compression bandaging. Okay, so here we are, Billy. Okay, so here's the bandage inelastic. See, I stretch it. Okay, fully stretched. That's it. Here we are, stretched, fully stretched. Most of the bandages in the market now are used are inelastic bandages, all right? They have been shown, and Hugo Patch, who was instrumental in writing that STRIDE thing, he did a lot of research with his institute on inelastic bandages. So most of it have inelastic bandages involved, okay? The Australasian guidelines talks about it, all right? And more we go away from elastic bandages to inelastic bandages. They are applied under full stretch, okay? And here you see also on the pressure mapping on the graph now, if you look at it, inelastic walking, it's like a sleeve around your calf muscle. So the calf muscle bumps against the inelastic bandage, and you actually achieve a very high walking pressure, all right? And when you lie, so that's really good because it empties out the lower limb, all right? So if you lie with an inelastic bandage, the pressure is very low because you don't use the calf muscle, okay? And standing again and walking again and exercising, you get very high pressure. That's what we want. We need high pressure when you're walking and low pressure when you're resting. So that's cool. Those bandages have to be applied every 24 hours. Otherwise, they slip down, all right? Then we come to the multi-component bandaging system, and they really are the bread and butter in the community when we use the compression bandaging, class 3. So here's Coban 2, which goes padding inside in a compression layer on top. All right, there come many different companies to have multi-component bandages. Most of them are now cohesive. They stick to each other. The bandage sticks to itself, so it doesn't slip down anymore. Because this problem with the other ones, they slip down. They get very loose. You lose pressure very quickly. So these cohesive bandages are excellent. They're disposable. You can't use them again. All right, they can last for about 1 week. They come in different strengths. So here we are. We talked about class 3. Now we talk about class 2. Light compression is 23 to 32 millimeters of mercury. The Coban, which we use a lot, just the difference is the color. So you can see the different compression levels. So much about bandaging. Then we go into stockings. Now we go back to our classification system. Stockings class 1, all right. This is 18 to 21. TED stockings or thrombolytic stockings, they have class 1, all right. They have 18 to 20 milliliters of mercury when the pressure is at the ankle or at the lower calf, level of B1, all right. There can be above knee, there can be below knee, they're your flight socks, all right. And the way you measure them, we can show you that if you want, is the widest part of the calf and above the ankle. And then you go into this purple table, and then you choose the size you want. Sizing is really important, obviously, to get the right compression level. So as we go up to the next class, compression stockings get stronger. Class 1 is flight socks, preventing DVTs. Class 2 is when we often use for patients who have healed their leg ulcers, for example, or patients who have edema, pitting edema, and we want to empty the lower limb and increase the venous return. So class 2 stockings. Here's basically just slightly different pictures. They come open and closed toes. Use measurements is the same. There are multitude and hundreds of different models out there. It's just a matter of price, really. You go on websites and you can get stockings with, with sparkle jewelry on top of it and everything else. Of course, they cost, all right. We have the advantage in our clinic that we can give the stockings free to patients who will see us. And that's pretty good. That has changed the last year, which is excellent because pricing is often hindrance for people on pension. Now, we like to use class 3 compression stockings, but the problem here is that they get quite tight. And people find it really hard, especially when you talk about aged people that they have or rheumatoid arthritis or they don't have the strength in their hands to apply class 3 stockings. One way around this is to use compression hosiery or stockings where you use the physics, basically, where you can apply 2 socks on top of each other. So you have 2 stockings. So you have an inner sock, which is 10 to 24 millimeters of mercury. So you leave them on day and night, and you put a second stocking on top, and you add those pressures up, and then you get a class 3 stocking with up to 45 millimeters of mercury. That can be very useful for people even with leg ulcers, because remember, we need usually class 3 stockings, class 3 level compression for healing venous leg ulcers. Okay, so people who are youngish, who are working, who are flexible, they often do the dressings themselves and wear those compression stockings, and they might be seen every few weeks by the nurses. I want to show here our colleague, Abby. She runs a compression clinic. She does a lot of work. She measures and fits the off-shelf stockings and makes custom-made hosiery. It's very important in troubleshooting it. And also does vascular assessments for varicose veins, for treatments, and also full leg bandaging. Abby asked me to tell everyone that to make sure that the stockings are comfortable, otherwise people won't wear them. And that's a real problem often, of course, is to have concordance for patients wearing the stockings over a long period of time. It's easy for me to say within 10 seconds is 10 years before you get any real problems. Okay, but it also means 10 years of stockings, and it's very cumbersome, especially in summer, putting them on, taking them off, and so forth. So yes, they have to be comfortable. People have to get good support and make sure that they replenish them, because stockings they last maybe for 6 to 12 months. Yes, good donning aids available. Different ones, and often we use a lot the Magnite on the left that has magnets involved. It's like a slippery Sam. We find that people, even aged people, can use it very nicely. Okay, those ones in the middle, they're also used. It can be a bit sort of cumbersome and have to be careful not to bump and cause skin tears. And tricks of the trade, which we talk about when we do the compression workshop. Now, remember, any compression is better than none. Liners are very comfortable to wear. There's very light compression. So that's 10 millimeters of mercury. Okay, that's half the compression compared to class 1. So we call them liners. They're very suitable for the vast majority of elder people. And often we increase them to 2 stockings on 1 leg if tolerated, because, the compression then is twice, and maybe have just 1 during the day and 2 during the night. And that can be very useful for depending edema. Now we come to the tubular bandages or the tubigrip. So tubigrip is, depending on the size, if we get the size right, it's 4 to 10 millimeters of mercury. The sizing is really important, so you have to make sure you got all the sizes you need available. Double layer if tolerated, on the principle that compression doubles if you use it. So the first layer is from the forefoot to below knee, the second layer to ankle to below knee. And I had a look. We used to have shaped tubigrip available within New Zealand. I know that Julie Betts in Waikato, when I visited her clinic a long time ago, she had them available also in Rutherford. I couldn't find them. Anybody out there who knows where you can get shaped tubigrip, let us know, please. Here we are, a plug for the New Zealand Wound Care Society. We write out a tissue issue newsletter every couple of months. So in the current tissue issue newsletter, there is a really great picture guidelines here for how to apply tubigrip. It sounds simple, but it isn't. Tubigrip is quite dangerous. It can be dangerous, if you don't apply it correctly. It can cut in here on the instep and cause really nasty skin problems. So Mandy did a really great job, and she's also our president from the Wound Care Society and also coordinator of a league, also advisory group. So you can read through this. I like how she talks about it. Cover the leak first with soft band, and then apply and fix the soft band with a great bandage. And make sure it's not too loose and not too tight. And then cover the grape by applying tubigrip of the appropriate size. Make sure that you know what the blood flow is like, all right, and so forth. So it's a really good resource to have, and I would encourage you to have another look if you use tubigrip as compression. Excellent. So now we come to custom-made compression garments, reps, and sequential compression devices. So those really devices which often prescribed by Rebecca, the nurse practitioner for vascular, in a vascular clinic, or the wound specialist clinic and so forth. We wouldn't expect people in the community like the UNGP or and so forth to prescribe this, but it's good to talk about it to complement. So custom-made compression garments are complex to measure. There's no way around it. Abby is an expert in this, but often Abby will also get the company expert to come if it's a really complicated patient or complicated measurements. So we work with a company expert who has been in the business for 20 years and really knows the tricks of the trade. They are costly because they're often not publicly funded. Okay, and a garment can set you back $600-700 in no time. They are always they can be inelastic or like a short stretch, or they can almost be not elastic at all. All right, and we got some custom-made garments here if you want to have a look. And then we talk about the adjustable compression wrap. They're really, we use them for the last few years. They are excellent and also useful for patients who find it quite hard to put stockings on. They, I would say, probably have replaced 30 to 40% of compression stockings in the last few years. They have Velcro elastic drawstrings that textile will overlap and they can be completely inelastic or a short stretch. They're quite stiff, okay, and have a high working pressure. So you put them on, they have a tubing grip underneath. And I put on that's just one company, all right? The other companies are similar systems. They got this building marking system where you can prescribe the pressure. All right, so it's either 20 up to 50 millimeters of mercury. So patient get the hang of it very quickly and works very well. It does work with minor wounds, not with large wounds or with very oozing exudate, all right, where we go back to compression bandaging. This is the order form as a prescription for this particular type of flexi wrap. You can see that we that we prescribe the class, which strengths we want, signature, and so forth. Well, Rebecca talked about, and I think she will talk about in her case studies about sequential compression devices. You will know what we're talking about because they're used in post-surgery since many, many years now to prevent DVTs. These are the pumps who mimic the calf muscle, basically action, all right? And there's a pump attached to it, Velcros, and they're really comfortable. I tried it out myself, and it's actually really soothing. We have different systems. Rebecca will use it for lymphedema patients. We will use it for patients with venous ulcers or edema, like that sleeve down there. It's got a zip, okay? So patients can put it on themselves, put the zip on, and then can dial the pressure they want or prescribed and how much they tolerate. Often the patients, find out how they best sort of can deal and tolerate the pressure. And they can be very effective. A patient directed, however, they are expensive. So some we have managed to get through ACC. Some we have some pumps which we bought through donations. Okay, so we have a number of pumps available, but the sleeves, you still have to pay for them. And they can be in a few $100s in no time. Here we are. Rebecca is our specialist, and it's fantastic. And they get very complex. That needs to be done by a specialist in conjunction with the patient. I got almost finished now, but I want to finish with another patient of ours. And he speaks for himself.
Initially, I knocked my left heel on a post at the bottom of the bed, and a blister developed. It then broke down to leave a raw wound. This was seen initially in a hospital clinic, and a dressing was put on. Subsequently, I was having to do this myself at home with my wife's help, and also the district nurses were referred to look after the wound. For about a year, the dressings were being changed regularly, but little improvement seemed to occur. In the wound clinic, compression bandaging was started, and it was very significant, the amount of healing that started at that point. It's gone up now to the point when I'm told that the wound has virtually healed, which has been a very good result from my point of view.
So my apologies for this, I call him John, to turn upside down, but so be it. I think the story is powerful, and also the pictures are powerful. On the right side, when the patient was seen for the first time in the clinic, and then on the left, where there was an accident, an injury caused by furniture. And you can see on the 30th of November when he was first seen, and then compression was applied within 4 weeks, the wound halved in size. And with another 4 weeks, the wound has almost healed. So compression does make a difference. Of course, there are contraindications with everything in life. You have to be careful. ABIs, very low. There's no magic number. Has to fit within your vascular assessment. All right. Then acute heart failure. Like we see yesterday, lots and lots of patients are in chronic heart failure. They're perfectly all right being on compression bandaging, and have so for many years. But if they go into and get admitted for the medical ward, for example, for acute heart failure, we never put them in compression. Doesn't make sense. We'll either have the swelling down in the legs and then compromise the heart even further. And to be really careful with neuropathy, it has to be closely supervised. We do put patients, especially diabetes patients, or patients with diabetes and leg ulcers and they have neuropathy, we put them in compression bandaging, but they have to be closely, even more closely supervised. Allergies, if patients are intolerant to bandaging or to any tension around their leg, and you get them claustrophobic, they just can't take them. And you need to work with the patient, all right? And it all happened to me. I thought I know better, put the patient in stockings, and district nurses warned me about not to because of the history, blah, 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 blah. So what happens, I sort of tried again, and then 2 days later, I get a nice present, a little box, and there was a cut-up stockings in the box, all right? The patient basically cut it off in the afternoon, all right, and say, oh, I'll show you, all right? So, and then concordance, which is basically another word for basically just work with the patient and make sure, like ABC, it's comfortable, they have support, and that they can work with somebody. So in summary, compression therapy reduces lower leg edema, increases the venous return, all right? Much more sufficient than other, for example, medications. Follow health pathways in your area, local guidelines or international guidelines, which we showed you once, and we're fortunate to have the Australasian guidelines, which are the envy around the world. Conduct a vascular assessment before starting compression, and we always apply graduated compression. The highest pressure is at the ankle. There are many compression systems available. Usually we find one which fits the patient, and refer to the wound care service early. We're all a team, we're all working together. Refer as early as you can, don't wait too long. Especially for lower leg wounds, we talk about the first week of before the wound gets established, all right, before we dealing with more and more a chronic or hard to heal wound, refer the patient. Again, I want to highlight the conference in Kirikirioa in Hamilton on 9th to the 11th of September this year. We would love to see you there. And also put a plug in, and I won't go through the slides, but you can see them later on. And when you have a look at the webinar again, there are some slides about the Wound Care Society. We're all nurses, we're all volunteers, we're all compassionate about what we're doing, working together for the patients to make a difference. All right, we have the Vice President, Rebecca, with us tonight. I'm the treasurer, okay, and advantages is you have a network of specialists, of wound nurses. They share their experiences, expertise, and knowledge. We have a lot of information on our website. We have this tissue issue. We have webinars available. For example, this webinar will be available on the website too. And one thing I wanted to show you is if you are interested in doing your own ABI workshops or attending workshops, but you're not from within Otago or Southland, okay, here are the area representatives in New Zealand. So every area has a rep, basically, who works in a wound clinic or can refer you or can advise you of how to get you skill in terms of ABPIs. So just get in touch with the Wound Care Society and email our administrator, and you will find help. Thank you for listening and watching my presentation.
Thank you, Emil. Could you run on to the videos now? We'll show two more videos from our sponsors.
Venous leg ulcers are a serious complication of chronic venous insufficiency. Disease or disrupted function of the vein valves allows blood to flow backwards, increasing the pressure inside the veins. This venous hypertension can cause edema and swelling of the leg, increasing fragility of the blood capillaries and the skin, leading to ulceration. Compression therapy provides a stiff and anatomically shaped cylinder against which muscles in the calf can contract. The increased pressure is distributed evenly throughout the leg, supporting the calf muscle pump. This decreases the capacity and pressure in the superficial veins, supporting valve closure, which aids venous return by increasing the blood flow velocity in the deep vein. This reduces oedema by opposing leakage of fluid from the capillaries into tissues, encouraging lymphatic drainage, reducing exudate, and minimizing skin ulceration. The effectiveness of compression is determined by the degree of elasticity, also referred to as stiffness. A compression system that has SSI under 10 millimeters of mercury has a low stiffness and is considered to be elastic. A compression system that has an SSI greater than 10 millimeters of mercury has high stiffness and is considered to be inelastic. A high stiffness compression system produces greater fluctuations in pressure than a low stiffness system. This is sometimes referred to as the massage effect. Simple muscle contractions during exercise, including passive movement of the ankle, can significantly improve venous return. For more information, contact your 3M representative or visit our website.
Your second speaker tonight is Rebecca Aburn, who joins us again after presenting a really interesting topic yesterday. Rebecca is a nurse practitioner at the Southern District Health Board based in Dunedin, Otago, and tonight she is presenting on case studies. Please remember to log those questions. We've got quite a few lining up, but we've got room for more. So welcome, Rebecca.
Thank you. Good evening, everyone. I have the pleasure tonight being able to present to you some of the case studies that we've been dealing with recently, and I've got 5 case studies here, and I've tried to stick to the edema and sort of stay away from the wound care side of things, because obviously we do get complex patients with wounds that are difficult to heal, but actually 80% of what we see as Emil's presented tonight are venous leg ulcers that are usually as a result of trauma of some description for some patients, or spontaneously happen from venous eczema, and are usually quite easy to treat. It's only about 10% of ulcers that are sitting around the hard to treat and hard to manage type ulcers, and then there's 5% in the arterial ulcers. So what I wanted to do is focus on the majority of what everybody will see out in our daily practice, rather than getting into some complex inflammatory type ulcers and things that are actually very rare. So these are straightforward case studies with a little bit of a twist in one or two of them. So the first patient is an 80-year-old gentleman who presented to his GP after developing significant what he describes as redness and edema, heat and swelling over both his legs. He was treated at the time in the community as a cellulitis with unknown etiology, but they were quick to refer him to the vascular department, and we do have a process in our vascular department that if they do have an open wound, we try to see them within 2 weeks of the referral. So we are wanting to try and get the diagnostic side of things done for these patients as quickly as possible, because, as I've said, 80% of patients are usually venous and relatively straightforward to manage. So he presented to clinic, and he presented to my clinic. And he, on the right-hand side, is the really complex measurements you can use when you're doing an assessment for someone who has edema. Not everyone has time to go through and measure the leg from the first metatarsal joint right through to the thigh. This is just one example of how you can measure edema in particular. At the time, we did take the photos, digital photos, with using our silhouette photography system. And but basically what you can see on the right-hand side is the difference of more than 2.6 centimetres in the size of his leg. So he had a significant edema. And we also did some other diagnostics, because he was an elderly gentleman. So we checked his renal function to find out if he was in renal failure, which he wasn't for him. We checked his albumin and creatinine ratio, because he was also diabetic. Checked his just a standard tests. We did a CRP to see if he had an infection, which often, this is a little plug for red legs are not always infected legs. Red legs could just be from varicose eczema and or arterial insufficiency. So we have some examples of patients who've been treated for foot infections, which actually turn out to be arterial insufficiency. So the CRP showed that he didn't have any current infection. His HbA1c is very well managed, his blood sugars are well managed, and his lipids were within normal limits, and he had normal thyroid function. So this patient was, it looked like at this point that we were just dealing with some swelling as a result of a recent cellulitis. So part of the vascular assessment, as you know, is that we need to look at the limbs and find out if what we're looking at. So we had mild pitting edema to the pretibial area. There are varicosities and some status changes that were noted in the gaiter area. The calves were supple and non-tender. Bilaterally, there's no dependent ruber. So a dependent ruber is when a patient who has what looks like a red infected foot which is actually vascular insufficiency. If you hold the foot up above the heart, the foot will change colour and go pale. It's a very quick test to tell us whether they have vascular insufficiency or arterial insufficiency or an infection, because obviously an infection, the redness will not go away and it will remain the same. We listen for bruits. It's not something that everyone has to do, but we listen to see if they've got any other arterial indicators that would mean that we are looking at an arterial issue. He had good femoral pulses and palpate able to palpate distal pulses easily. His ABIs were 1 on the right and 0.9 on the left. And we talk about the sound that we heard, which was 2 sounds when we heard his arterial flow. Capillary refill was good. He had mild loss of sensation. He is diabetic, but he was relatively well controlled. So I was just trying to have a think about what we were seeing there. So he did have a positive Stemmer's sign. So he did have some swelling down to the feet, but it's mostly related to chronic venous insufficiency by the feel of things at this point. So he had a problem list of chronic bilateral leg swelling, chronic ulcerations, which he'd had for quite some time. He had normocytic anemia as well. His diabetes was pretty well managed, but over his history had been not so well managed. And he also had distal swelling of his fingers, and so he had osteoarthritis, which he was being well managed. And this just goes into a little bit of detail around the differential diagnosis, just so that everyone's thinking about, is it chronic edema that he has caused by some lymphatic system change from the infection, which can be something that happens with a recent cellulitis, or is it venous insufficiency, congestive heart failure? He does have shortness of breath at times and lower leg swelling. But it wasn't a recent thing. There's no rest or dizziness, no chest pressure or changes. So malignancy, it's trying to think about whether he has those wounds are malignant type wounds. So these are the types of things we're thinking around. And I always put a plug for, we talked about it last night, about medications, any new medications that we could put down to the sudden swelling, but he hadn't had any. So you rule in and rule out these things in your head, and you're trying to constantly be thinking about what this might be, the underlying problem for this patient. So it's starting to look like it's initially a swelling that's happened from an infection, but he's probably got some venous insufficiency at the same time. And so what do we do for this man? This is an example of the wound after we have treated it. Bilateral leg edema with chronic ulcerations. We clean this ulcers. We use Prontastan as a wound irrigation solution to remove any slough, AMD. He had bilateral compression with Coban 2, which was applied to the pretibial area. And this was treated while he had the wounds twice weekly. And once he had finished with the Coban and the bandaging and the wounds had healed, we put him into wraps for long-term management. And this is sort of pretty much a scenario that we would get for most of our patients who come through. So he may have started as a trauma. He works in the garden a lot, so he could have nicked his skin or just even dry skin can cause a trauma. It breaks down, causes an ulcerations in the gaiter area. He's got all the signs and symptoms of venous insufficiency. And then it's from the moment we see them, it's about how we're going to manage them for the long term. So we talk about wraps, we talk about some sort of compression therapy. He was never going to be a candidate for compression hosiery because of his osteoarthritis of his fingers, so we start thinking about wraps. In the inpatient setting in our DHB, we're able to order wraps for patients now as inpatients, but as an outpatient, they have to buy their own. They are $137 each, and so that is quite prohibitive for some patients. So we're looking at, we've already found funding for our hosiery for patients, because we found that was one of the barriers to them to being able to wear compression is cost, because it's an ongoing cost. It doesn't just stop at that point. It doesn't just stop. It carries on. So for us, our patients would have their first set of hosiery is given to them from the clinic, and then our, as I say, as inpatients, I try to order our wraps for them when they're inpatients, because it's obviously a huge cost to them. And I'm really lucky that I have a great charge nurse and team that I work with in the hospital that allow me to do that, because it is a bit costly, and I'm sure that it's increased the budget somewhat, but it decreases the readmissions. So the next patient, I talked briefly about this gentleman yesterday, but I wanted to go into a little bit more depth because the team in Invercargill did a really good job with this guy, and it was obviously my initial assessment and script that we made for him, but it was the team down there that actually pulled us over the line. And this is often where you guys out there, we see the patients maybe once a month, every 6 weeks, but it's the plan that we put in place, and then it's the plan that happens out there that actually pulls these patients over the line to wherever it is they want to be. My biggest experience with treating patients with edema is that they have expectations, and we need to make sure that we understand what they are, that we are enabling them to be wherever they want to be on their healthcare system, the healthcare journey, which is the most important thing for me. So he's an 82-year-old gentleman who lives in a rest home. He had long-term edema, secondary to chronic venous insufficiency. We know that because he's had venous varicose veins done. He used to wear compression hosiery, but he found it too hard to get on, he also had osteoarthritis of his fingers, and this will be before we had the ability to the wraps. Wraps is something that have come in over the last 10 years and have become more and more available and more accessible and affordable for patients. So he did manage stockings, but he stopped sort of wearing them. He was a bit of a vague historian. The nurses in the rest home heard that I was in Invercargill and that my specialty is lymphedema. And when he walked through the door, I thought, wow, I'm not sure how I'm going to be able to help this young gentleman. It's pretty sprightly. So the big key thing for him is that left leg was 3 times bigger than the right. And he has his pants, terrible spelling, has his pants specially made to accommodate the swelling. He lives in the rest home. He's happy with the mobilisation and his quality of life. And this is where we talk about my aims and his. My aim was to try and get him 2 skinny legs, but distal from his knee to his thigh was normal size, which is really interesting. So he had what is considered a long-term effects of chronic venous insufficiency, left side worse than right. He didn't have a history of multiple admissions for cellulitis. He's had relatively good skin care. He's been relatively lucky in his journey in that he hasn't had a whole lot of side effects from having a big swollen leg, except for decreased mobility. But yeah, interestingly enough, from the knee to his hip was normal size. So again, for him, his extremities were warm. The lower limbs were obviously unilateral, but he did have evidence of skin changes on the right as well, and no evidence of arterial disease. He had good femoral pulses. Was unable to palpate any pulses in his feet due to his swelling, and we also didn't do an ABI on him. And I'll talk a little bit about this. The reason some of the patients, and there's 2 or 3 patients in this that I present, that we are unable to do ankle brachial indexes on. And so a little bit, we talked about it last night, we touched on it. It's about the history. It's about he can walk around his rest home with no claudication pain. He is one of the risk factors is being male and over the age of 75. There are risk factors he's a non-smoker. I think he smoked very early on for a very short period of time in his life, so it's another risk factor. He didn't have any other cardiovascular risk factors. He had well-controlled blood pressure. And so when you start to put all of that together, the risk of him having an arterial insufficiency became less and less. And so then you start to use your clinical reasoning and clinical judgment and know that treating edema is far outgoing to weigh not treating it. So, and then you would do things like put on the compression therapy, as you see here, but you would give them really clear guidelines about when to take that off. So if they were starting to get any discomfort or pain, you can just take it off. It's no problems. This man had had this swelling for a long period of time. So whatever we were going to do, we didn't want to make it a dramatic change. We just wanted to make it a simple, graduated change. And so we actually started him once we had his goals and expectations was that he wanted to wear the same pants. He didn't want to have perfect legs. He's not going to have perfect legs. I always talk about skin care, getting in between those toes and actually having a really good skin regime. And I'm not sure how much I talked about this last night, but certainly when I went and did the lymphedema course, we had Jan Rice, who is a guru in wound care, come and talk to us about skincare regimes, and it's one that I've utilised with quite a lot of my patients who have just leaky legs, especially big edematous leaky legs that have got often sloughy ulcers or just sort of superficial type ulcers on there, and lots of crevices and lots of unusual skin folds. We use it for the bleach bath is what we call it for children with eczema. And I remember when I first heard about it, I was horrified that we would put bleach into a bath and then stick a child in it. But actually, those of you that know what microdiosin is, it's actually got sodium hypochlorite in it, because the first time I sprayed it, I was like, oh, it smells like bleach. So it is a tiny nip of sodium hypochlorite in it with the surfactant that they have also added to it. So it is an amazing way of managing the skin. And so skincare regime would need to be something that, again, is prescribed and that you do on, in the case of these really big leaky legs, on a daily basis. So I'm often sending the scripts out to the nurses, and I get phone calls to say, really, you want to put some bleach in? So, yep, I do. I want to get a bucket of warm water, and I just want to put a nip of sodium hypochlorite in it and put the patient's feet into the bucket, soak them, get in between. And we talked about this again with a patient I had on the ward. It is really simple. Jan Rice, I didn't make this up, Jan Rice put it together, and it's been a really effective way of managing those leaky legs, and I've found great success with it. Needs to be done daily. It needs to be whoever's you've engaged to help you with it, you need to have them engaged and the patients engaged. And it needs to be done correctly. And once you've then washed the leg and dried the leg, you then need to re-moisturise the leg. So you need to use fatty creams, what we like to use, because it's got no but you can use any emollient. In some cases, if they've got a varicose eczema that's quite bad, we would prescribe Aristocort ointment. It's sort of a middle-of-the-road steroid. I tend to try and trial that for the first sort of 7 to 10 days and see what the reaction's doing. If it's starting to improve, then we know we're on the right track. I used it recently with a patient with an ischemic foot that had swelling that also had a lot of exudate, but it's like the old potassium permanganate, which we find really hard to get a hold of now. It does help to dry the skin out and dry out the it kills things like Pseudomonas, and it kills staph. It kills all the things that are causing the skin to be irritated. But you've also got to remember to always put the moisture back in. Obviously, education for the patient around skin care is important. Exercise is important. Manual lymphatic drainage. You can teach patients, if they can get to their swelling, to do the manual lymphatic drainage themselves. Pneumatic compression therapy, which Emil's talked about, which isn't usually available for patients down in Invercargill at this point, but we are looking at getting some pumps down there. And compression bandaging and hosering. So in the case of this patient, we put him into Coban 2, and the nurses down there continued to do that weekly, and after 6 weeks he was able to be put into wraps, and he's now in the same pants. Now it's a big, once you start this program, whatever program you start and prescribe with patients, whoever you're working with, whether it's the district nurses, the practice nurses, or in the case of this, the nurses in the rest home, everyone needs to understand what the aims are, including the patient. And it's really important that we're all working on that same goal. So this is what we did for him, and this is how we worked it out. So the case study 3 is the one I talked to you about. Originally, I met her, the district nurses had been seeing her for about 18 months every day to treat. It doesn't actually look that bad in these photos, but that right leg is leaking so much that, and the back of her leg is just all macerated. And she had been at home just wearing, they'd been treating her each day, and she wasn't in compression because they hadn't been able to do ABIs. She's morbidly obese with a BMI of 65. She's on home oxygen and she's on CPAP at night. She has a history of venous insufficiency. She used to wear stockings many, many years ago, but stopped wearing them because she got too big. She's got hypertension, hyperlipidemia, acute rheumatic fever as a younger child, type 2 respiratory failure, and she's a non-smoker. Her medications were relatively straightforward. She was on oxy for her back because she had got terrible back pain. And so when I met her, we instigated the daily bleach washes and moisturiser. And because in our service, just so you know, Coban costs $36 a packet. So we used for her the long stretch shore press high compression bandaging. And with this, normally when you do compression bandaging, you do 50-50 and you go up the leg in a beautiful way. And I think I talked a little bit about it yesterday. I had to teach the district nurses how to follow the leg up and not to be frightened to not do it 50-50, but as long as you got coverage. And so we taught them how to do the her legs and to be able to help her with her compression. She's limited by what we can do for her. She won't fit my compression pump because her legs are too big. You have to have legs that are under 107 centimetres, and hers are definitely not. Her thighs are around 150 centimetres and her calves are 78 centimetres when I met her. Our biggest problem is the risk of infection. She was on and off antibiotics, so we needed to try and fix that for her. And as I say, our compression options were pretty limited. Coban does do a bigger than 10 centimetres width. It does a 15 centimetre width, but again, you'd need to change it daily, so you'd need to get commitment from the DHB to fund that, because initially she needs it daily just because of the condition of her skin. And when I did her examination, she had no obviously signs of varicose veins. I wouldn't be able to see any varicose veins because how big she was. She had positive Stemmer's sign bilaterally, where you can't pick up the first and second skin between the first and second toes. I was unable to palpate her pulses. She had hyperkeratosis and she had lymph fluid leaking out of her legs. So the front of her legs was actually lymph fluid that had come to the front and was just leaking out and causing the burning. Significant skin folds that I could put my whole hand underneath and lift up. And so they're a breeding zone for infection. And pitting edema. She's obviously morbidly obese as well, and you know, not able to even sleep in her own bed because she had so much leaking out of that right leg in particular. So her goals were to stop the leaking. It was affecting her life. She's had it for 18 months and things weren't getting better. And so that's the treatment we started, the daily wash with sodium hypochlorite and water, moisturising with fatty cream. We talked about education around diet, exercise and skincare, in particular, engaging her to be able to do some sort of static movement. As I say, any massage is too late. Pneumatic compression we weren't able to use, and so we had to use compression bandaging to try and and this is the tightest, at its tightest, it was the only way we could do the kind of lymphedema management that she needed. How did we do? Not so well sometimes. I've put the photos about how we did the compression bandaging for her, and it was really complex. Lymphedema in particular, for doing compression, you need to follow the contour of the leg rather than the traditional 50-50 as we talked about it. You need to have complete coverage, and the second layer is applied the same way, or however, and it's a 6 to 8 week treatment, and then you can try maintenance, which we did with this lady. And they did stop. We fitted her with some wraps. We finally got her into some wraps, but unfortunately the leaking reoccurred because there wasn't enough compression being put on by the carers, which isn't anyone's fault. So what we did is we actually spent a lot of time. We ended up teaching her husband how to use this compression, and we supply them with this, and he does this for me now, and I haven't seen her. I saw her recently just before Christmas. She had corns on her feet. That's why she came to our clinic rather than needing compression. I did go over and do another little review, and she had a few areas that were sort of starting to break out again, and we talked about it. And so her husband now will just ring me if there's any problems or if he needs any extra compression. It's sometimes it is really complex to get there. It took us about a year to get to an agreed area where he was really happy to be doing the compression, and we're managing to keep her skin under control. And it has been challenging because she's been in and out of hospital with other physical health problems not related to her legs. And that's when things fall over sometimes because people are a bit frightened to get in there and do the compression. And she went away to Christchurch for the first time in 6 years. So I'm pretty pleased that her and her husband were able to get away. She's not been able to leave or get out of it and go away for a period of time for many years. So I think that that's probably the best outcome for this lady. And as I say, we still keep in touch with her. We've got an open door policy where she can, and her husband can just give us a call if they need anything, which is great. And the district nurses aren't visiting her daily, which is fantastic for them. The fourth case is a relatively young lady who came to me, and I say young, she's the same age as me, she's 47, came to my clinic, and she said to me, I've been to see all of these consultants and they just keep telling me I'm fat. And I said to her, and how does that make you feel? And she said she's frustrated, and I should have probably taken a better photo because from her waist up, she's quite small. From her hips down, she's got the jacket on, it doesn't really appreciate. From the hips down to just above her ankles, she's much bigger than normal people would be. And around her knee area, she's got quite a lot of fat deposits. And if you zoom in on her feet, if you're lucky enough to get in and have a look at her feet, they're normal size, and she had a normal pair of shoes on. And I think it was Emil that said to me, oh, I didn't know that lipedema has normal size feet. So that's a good thing to know. So this young lady came in, and she's got not a huge background. She suffers from depression and obesity. She drinks 1 to 2 bottles of wine a week. She lives with her partner and 3 adult children. She's got no history of DVT or varicose veins, gets no pain when she walks, except she does get some sort of thigh tenderness at times. So that's just to look at, she had a negative Stemmer's sign, pulses in her feet were easily palpable. She had an APPI, which we could do on her of 1. She had this adipose tissue was distributed from the sort of upper calf thigh region, and no pitty edema. When you put your finger down on her skin, it doesn't pit at all. So that's a really, if you look at the skin, it's quite interesting that it doesn't do that. So these are what she was told. She's tried furosemide, she's tried all sorts of things that the GPs tried to help her with swelling. And So the pain that she experiences in her thighs was probably, and around the knee joints were probably the things that annoyed her the most. Skincare, she did moisturise using fatty cream and looked after her skin pretty well. She didn't have any areas of breakdown. We talked about education with diet and exercise, engaging her calf pump. She walks everywhere. Then we decided to trial a pneumatic compression therapy machine with her, and I started the trial at 80 millimetres of mercury, and we put her into some compression bandaging, which she didn't really like the compression bandaging so much, but she said it helped. But what did help was a pneumatic compression machine. And she found immediately after a treatment, she had increased, and for about 24 hours to 48, depending on what she did, she'd get increased mobility through her knees especially, and she felt, and this is subjective, this is why we probably need to do some study around it, and there hasn't been much study around it, she felt much lighter, and I sort of put that in inverted commas because it is an interesting concept, but she felt lighter and more at ease with herself, which is quite phenomenal really, because she'd been spent all this time with people telling her she's just fat and just go and exercise and lose weight. And to be told that she actually has lipedema and there is a problem with her legs has been revolutionary for, I think she cried in the clinic when I told her, which is pretty phenomenal. So she ended up buying her own pump. She came and used mine a few times. She was from Invercargill, so she made the effort to come up to Dunedin, and I took the pump down to her a couple of times for her to trial, and she found her pain reduced using the pump 3 times a week. She bought her own pump, increased her mobility, decreased her leg size by centimetres, and overall improved her quality of life. Interestingly enough, I've seen her recently in clinic, and she's not been using her pump so much, and she's got a little bit of pain back. So we talked about that, about getting back to using the pump, and it works for her. And again, it's been something that they've trialled on some patients with lipedema that I've trialled the pneumatic compression pump on. It hasn't worked. But they do find using hosiery quite helpful, whereas this lady found hosiery just not helpful at all. So the key to finding a compression therapy or a treatment program that works for the patient is sometimes a little bit of adjustment, a little bit of give and take, a little bit of, this isn't working, I need something else. And often I'll give patients my phone number so they can ring me and say, oh, it's not working, or what do I do? And we recently had a patient who is actually palliative, and she has CA cervix and has had surgery, and her left leg was so swollen that she couldn't move. So she came to me, we put her into some Coban for a few weeks, and she bought her own pump, and she's now using it on a regular basis. And really it's about just being able to have mobility and just be able to not have that big, dead, sort of heavy leg that she had. So it's been quite, that's been another good outcome. So the 5th case study I am showing you is one from clinic down in Invercargill recently. We work with, we've got a new vascular CNS down there, which is Pagan, and she rang me, and she had a fit, healthy 72-year-old male who presented with a medial toe ulceration, and which started as a wee blister after some sort of lower leg swelling that had happened recently. Pagan rang me, and she had an APPI of 1.3, which we know is slightly elevated with calcified vessels. And so this is a proceed with caution case study, I presume. And this is the time when I'm being asked, should we put compression on? In the back of my head, we always say to not compress with a swollen leg is often detrimental. And we had a case study of a patient, a case that Mrs. Kreiser and I were in Invercargill. Again, I just happened to be doing a clinic down there in Invercargill, and we have great cases down there. And a lovely orthopaedic registrar came and said to us, hey, we've got this patient on the ward who is going, this is on a Friday, who's going forward for a below knee amputation on Monday for a left lateral non-healing leg ulcer. that she's had for the last, however, I can't even think how long it's been. So we trot up there and I feel the patient's pulses, and I turn to Mrs. Kreiser and I say, but she has pulses. Why are they cutting her leg off? And the registrar says, because we can't heal the wound. And Joe and I look at each other and say, we'll put compression on her, see what happens. And the patient laughs and we say, no, we'll put compression on you. So she has her leg and she has a healed wound. There are further stories about this lady. She does get another wound, but we put compression on her. And we healed her beautifully. So these are the ones where you sort of and ah, but we and ahed on this patient. He had pitting edema, and he didn't have any dependent ruber. He had no claudication pain. Ankle brachial index was 1.34 on the left and 1.21 on the right. Capillary refill was less than 3 seconds. He had good sensation in his feet, which is key. And it's not hugely swollen legs, but enough that it would slow the healing down of that blister that he had on his foot. So we and ahed, and his history, we took a really strong history from him. He didn't have any history of claudication. He's normally a fit and healthy 72-year-old gentleman. And the biggest problem is that he came from Queenstown, and obviously Pagan's in Invercargill, and I'm doing a virtual clinic from Dunedin, and this is Friday. So it's always a risk. But we were able to work with the Queenstown team and say, hey, look, we've done this with this patient. We're going to put him into compression. Would you be able to visit him the next day? We obviously counsel the patient what to do if he starts to feel uncomfortable, is to take the compression off. It's not going to hurt, just take it off. We have that long discussion and all the education that goes with all the written information that goes with it. And we were put him into Coban Light, because always go, like anything when you're prescribing, go low, go slow, and you'll watch and wait. So any compression is better than no compression. So we were lucky enough to be able to, we put him into Coban Light. We educated him, we followed him up with the district nurses. This is him, the wound that he had at the bottom of his foot that we were trying to address. So we're able to compress right up to the pretibial area. And we're very cautious. So he did have ABIs that he could have gone into Coban full, but we decided we'd go to the light and we'd get him followed up the next day by the district nurses, because there's a risk with everything that we do. And the results of that particular case was that we were rung, because Pagan came up for a week with us after that, and we were emailed by the district nurses that he's doing well, swelling's down, and the wound is healed beautifully, or healing beautifully. So sometimes you you weigh up the risks, and we felt that we were comfortable enough with his vascular assessment to be able to put him into compression to help with that swelling, to try and get it down so we can get that wound healed, because it's in a very awkward place, and if it gets even more swollen, it'll just continue to break down. And so that is where my case studies end. And I just wanted to do another plug for the APBI assessment workshop, which we've got on the 22nd of April between 12 and 2 at Dunedin Hospital. Having competency and being able to do an ankle brachial index is just another tool to be able to assess patients simply. And the patient where I gave an example of she was going to have her below knee amputation, we didn't need to do an ABI on her. We could feel her pulses, and she just had edema in her legs and needed to go into compression. And the patient in particular had been engaged with the health system a lot. She's a pretty smart cookie, and she didn't like the compression options that we'd given her up until that point. And so we had to be quite flexible with her and find a way that we could compress her. And we did eventually, and it's been really good. So being able to do that ABBI or vascular assessment has been is something that I encourage you all to be able to do, because, as I say, a little bit of compression can make a huge difference and can save limbs in the end. So thank you for listening.
Thank you, Rebecca. it must be so rewarding to do the work that you do, and to see those changes. Really, really inspirational. Thank you. I won't read out the final slide. It's been up there for a while for everybody to read, but I do just want to encourage people to register. There are limited places, and so don't hesitate. Do contact Ruth Mullinger via that email there, and place your registration. Now, we have plenty of questions, and you could stop sharing your presentation if you want to appear larger for the audience.
I don't think I want to. I'm large enough.
Yeah, I know.
You can stop sharing, Billy, if you want to. Or you can do it. Can you do it? Can you stop sharing?
Yes.
There you go.
Or slimmer.
Here we go.
Okay. Lovely. So, the first question, let me just bring it up. Do patients in compression need to rest and put their legs up?
Oh, that's a great question.
Yeah, that's a great question, and thank you for that one, because we get that all the time in our clinics, don't we, Rebecca? Patients come in and being told you put your legs up. They're usually sort of elderlies, 80 years old plus, and they follow the they follow the advice and put the legs up in the afternoon and to get the swelling down. Patients, and that's obviously people lose confidence walking around. They're not using the calf muscles, meaning the muscle will get smaller and smaller, and they will get unsteady and so forth. So when people in compression, we encourage everyone to walk normally, to do your normal exercises, to be as active as you can. You do not have to rest or put your leg up once in compression, because you actually want people to exercise, don't we?
Oh, absolutely. I think I had someone in my clinic with me, a postgrad nurse, and she said, a lot of what you're doing is actually telling people to exercise, and it's exactly what I'm doing. And if they can't walk properly, I tell them to get into the swimming pool, or I tell them to do passive exercises where they engage their calf pump so that it helps with shifting the fluid. And there is a green script that we used to give out a lot. I'm not sure where it went, but we give out green scripts for patients to enter into exercise programs. And we have exercise programs for our claudicants as well. So we encourage people to walk as they can. If they can't walk, then we encourage them to do passive exercises or some way of moving their legs. So no, we prefer them not to have their legs up and immobile, but
so often, really good exercise is this.
Yeah.
So just do the ankle exercise. And if you feel your calf muscle, just like this, everybody, and then crack a joke and says, you only have to do it 500 times a day. Okay. And people laugh, get the idea. And, if you just sit, basically, you can do that. Activate the calf muscle. It makes a real difference.
It does. It's a huge difference. And so all my sort of bigger ladies, especially if I can get their legs healed, I get them in the pool and get them swimming, because often they've got joint problems. And so I get them in the pool, and when I see them up at Moana Pool, I give them a big high five, because it's a big deal if you're a big lady to get into a pair of togs and go for a swim or do aqua jogging. But some of them, it's changed their lives because they've been able to get out and actually increase their cardiovascular exercise. They often meet friends at the pool and aqua jog with the friends. So it's been, I often tell patients if they can't walk because their knees are sore, or as soon as we get their wounds healed, we get them into the pool.
Great. That's good. Thank you. And what's the best skincare regime for leaking legs?
The one that I talked about. So like the bleach baths with the eczema kits, you put just a tiny little bit of sodium hypochlorite or genola into a big bucket of warm water, and you put their legs into it, and then you give them a good clean, and then you dry them down and moisturize them, and then put a secondary dressing on it, whatever that is. It could be simple like Mesorb or whatever highly absorbent dressing, and then they need compression, and the compression needs to be done daily. So that's why, obviously, we don't tend to use the Coban daily, but we do use short press or short stretch daily, and that needs to be done very firmly so that they can actually get the benefits of it. And if it's an eczema type skin irritation, then you need to treat it with some sort of topical steroid or some sort of lotion.
Thank you very much. Now I'm going to stay with the bleach because there was a question came in about the bleach. People really wanting to be specific. When you say a tiny amount of bleach, what is the actual ratio?
So it's 1 in 7. So it'd be 1. So if you have a look at these on our guidelines for the health pathway guidelines, there's actually bleach bath guideline, and it gives you exactly what to put in a bath, what to put in a bucket, what to put in. So I usually put a teaspoon in a bucket that's probably got 4 litres in it. It's not a lot.
So it's 5 mils for 4 litres, is that what you're saying?
Yeah,
not
a lot.
That's really helpful.
Yeah, it's not a lot. It really is just remember when I talked about it before, microdicin that you use as a spray, that has got sodium hypochlorite in it, and it's something like 0.2%, some tiny little percent of it in there. Yeah. And so it's really good for killing staph, but you've got to make sure that it's well diluted.
Yeah.
So we always talk about 1 in 7 is what they use to kill Ebola as a bug. So it's got to be really well diluted.
Okay, so that was really clear. So 5 mils for 4 litres is just a tiny amount. Yeah. And of course, it has to be the non-perfumed kind, doesn't it? Yeah.
Yes.
Cool. Yeah. Jolly good. And why would you use custom-made garments rather than general compression hosiery?
Size of the limb.
Yeah, the size and the shape of the limb. So people with
like my case study with the very big, unusual shaped legs, you're never going to get a off-the-shelf stocking to fit her. So she needs to come in and get each area measured up specifically, and then it's made to her sizing. And it's made to the shape of her leg. And so it might be that she needs a wider area through here. And so what they do is they then shape the garment, and it's custom made to their leg, so they can get it on, obviously. So someone like my lady that I showed who was with the morbid obesity with a BMI of 61, she's never going to fit anything off the shelf, and they can't afford to buy her the custom made. So that's why her husband does the bandaging for her.
So these are measured in many places and then basically made in Germany or Australia and then sent back. They're almost inelastic, all right, when you put them on. They can be made. We don't make so many anymore. I think the reps and so forth certainly has helped. The reps we talked about quite a bit has helped to reduce the amount of, but there are people out there who just wouldn't fit those reps even. Okay.
So while we're still on the compression, what are the benefits of using Tubigrip?
Well, Tubigrip is a safe way of applying it, and it does need less teaching. So it's something you can apply on the ward really safely if you follow those guidelines Mandy Pagan shared. Then it can be safely applied.
And you can give a little bit less compression. So single layer is only about 15 millimeters of mercury. So, and as we talked about, any compression is better than no compressions. But however, some patients can't tolerate any compression or just very light compression. And that's generally something that we try to increase over time.
Sure.
It's a good start.
Got a question here. Do you have the Rosedal system? I don't know if I'm saying that right.
Elastic.
Yeah,
this one.
Yeah, there's Rose Elastic. So that's Rose Elastic. That's the inelastic system. So it's a short stretch. All right.
So that is something that you promote, or you would.
They're just made by different. They've got
Companies
have got different names for them. It's a bit like
there's another one. It's called Comprilan.
Yeah.
Basically, it's a similar bandage. Probably comes from the same machine, just distributed by a different company. All right. So the really important bit is it's an inelastic bandage. So you applied full stretch. All right. Compared to the elastic one, where we have a long stretch. All right. 50% stretch.
And got two questions, but they're similar. So what kind of bandage is best for mobile patients? And what would you recommend for, there was another one here, for a wheelchair-bound spina bifida patient?
Good questions.
So the best system, I'll answer the first one due to the spina bifida.
Thanks.
So the best one, really, we always aim to go to COVID because it's just to a multi-layer system, all right? Because these are designed to stay for up to a week. So if somebody's mobile and he needs or she needs a compression bandaging, this is where we want to go because it has proven to have many benefits compared to that system here. It needs to apply daily. All right. So these single elastic bandages. You need a sub bandage padding always when you put compression bandaging on. There might be able to, it's because you can use it again. It seems to be cheaper, but there's a lot of nursing time involved. Because imagine coming every day to the patient. It has, so we always aim to go into the multi-layer systems. The one we use is Coban system. There's Pro4 out there from Smith & Nephew. Coban is from 3M and Pata Pro. Those three systems are now in New Zealand. Okay, they're, horses for courses, whatever you one thing we want to say is here, and I think I had it in my slide anyway, keep it simple. So we're using the KISS principle, really, keep it simple, because there might be 10 different compression bandage system out there. We're using one. So we have one here. We got a really good system. We got a spare one if somebody's allergic to this system. We have a different one. All right, but we keep it simple. So these are our three bandage systems in the Southern DHB. We do not have anything else. Yeah, but you have another 100 on the market. So we believe, and Mandy Pagan, if you're listening, mainly we work hand in hand in our one team. We have our guidelines. We always keep it down to a minimum of equipment, but good equipment, so people don't get confused.
And without your wheelchair-bound spina bifida patient?
Yeah, so with the spina bifida bandaging, it becomes relatively complex depending on the contours of their legs, the size of their feet, if they have where their feet begin and end, because they've often got quite short feet and clubbed foot. So, and depending on whether they have wounds or they don't have wounds, that also can lead you on a pathway depending on what you want to compress them with. Coban 2 comes in lots of different sizes, so you can get a 5 centimetre, a 10 centimetre or a 15 centimetre width tube. And it might be that, say, if you're just wanting to compress for swelling reasons for someone who is spina bifida, you could look at a 5 centimetre width to start off with around that foot. We've also used stump bandaging and taught family members how to do stump bandaging for patients who have spina bifida, because they need compression, but they also need specialised compression that actually goes from the forefoot right through. And there is a method to do that with Coban. If they were to look on the Coban website, it tells you how to compress feet and toes and there's a special way to do that, and you need the 5 centimetre Coban to do that, and it's just the video shows you exactly how to do it. But as I say, we have had good experience with someone who had they got custom made short flat stretch, they got some custom-made ones made for them. But we also have used things like stump bandaging, which gives some compression, but you can teach the families or the carers how to do it as well. Depending on the size of their legs, they could fit into some saccade wraps, which you do get a short wrap as well. They come in extra small as well, so that might be an option. It would really depend on the size and the circumference of the leg that we're dealing with as to what product you would then put on. Is that helpful?
Yeah.
Sounds very comprehensive.
Oh, okay.
I'm just going to check that you haven't already covered this one. Is the Jan Rice 3-layer tubigrip system advocated to use?
3-layer.
Have you heard of that one?
Yeah, she did talk about it when I was over in the lymphedema course. It's not something I've had to use, because I feel if you're going into 3 layers of tubigrip, and especially on the limbs that I deal with, I'd rather put them into compression and actually get some really good consistent compression. The good thing about compression is generally patients will keep that on. Tubigrip they see as big socks sometimes and can take off, and a little easier for them to not put back on. And 3 layers is probably quite complex for them to put on. So
it's quite a bit of pressure.
Yeah, and that would probably give the same amount of pressure as you would get with standard compression, either Coban 2 or our long stretch compression when we're wanting to put that on. So I'm not sure that I'm an advocate or not an advocate for it. I just think that there's better ways to provide that level of compression.
Thank you.
So can I just tell you, just show, because the difference with tubigrip is like a tube.
Yeah, it is tube.
It's not fenestrated.
Yeah.
All right. In the stocking, so basically it causes pressure on areas where it shouldn't cause pressure, like on the instep here. All right. In this compression sock is graduated, so it's sort of has a V. It gets wider towards the calf. All right. So it's much safer to apply. Tubigrip can be quite, that's why I mainly did this also, to make sure that we put padding underneath and don't underestimate the dangers of tubigrip. Right?
I'd also just say about tubigrip is that because people think it's safe to apply, I've seen quite a few 4-foot ulcers that are down to the tendon as a result of it's safe to apply, but it bunches up through there. And if the elderly patients that they're putting them on are quite frail skin, then you run into trouble with causing pressure injuries across those areas.
So I've used tubigrip, use those guidelines mainly in the presentation.
Yeah, definitely.
Please do not underestimate the danger.
Right, we're going to go over time a little bit. Is that okay with you two?
No, that's fine.
So what are the support stockings life expectancies? And also, how often should ABPIs be repeated when someone is in stockings in the ideal world?
I love the ideal world, because in the national guidelines that we put out, it should be repeated every 6 months to ensure there's no changes. But the reality is, if they're done 12 monthly, we're pretty lucky. Life expectancy of stockings is varied on how well they're cared for, but we say for the circular knit stockings it's 3 to 6 months. For the saccade wraps, it's around 9 months if they're well cared for, and for the flat knits, again, it's around 9 months as well. So it all depends on how well they're cared for, and often we get patients come to back to us, and it's around the sort of 4 or 5 months with a circular compression hosiery, and they've re-ulcerated. And so we know that they need to change their stockings just a little bit more often, which is a huge financial commitment for them, which is why we have, and Dunedin tried to fund that for them so that it's taking a little bit of the pressure off them.
And somebody's asking, what are these compression bandages made from? And do you have any experience with people having skin allergies due to those bandages?
What are they made of? They're where there's an elastin in it, or like a elastic layer. In the what is it? Right? We have a look.
Oh, you're talking about these
ones here?
You're talking about the compression bandages or the compression stockings, because they're all made of different things.
Yeah.
The question was about bandages, but I imagine.
Well, the answer is basically yes, you can have allergies to anything, really. We have people who are allergic to the compression system we have, and then we always try to use a different system, basically, which people are not allergic to. Or we use to be fast, a layer on top of the skin before we put the compression bandaging on. Yeah, you can have an allergy. What they're made of, synthetics and elastin, which is an elastic sort of component in it. Yeah.
They're made in Germany.
Yeah, all the good stuff comes from Germany. And
you're going to say
why did I do that?
Now that you mentioned it,
Now that you
made in Germany, all right. Medivan, double stockings, made in Germany, all right.
Do you know why they're made in Germany? Because in Germany, they have got the copyright for the machine that makes the actual stockings. And so it's been allowed to be replicated in other parts of the world, but only at a huge cost because the Germans got it.
Yeah, only a German engineered machine can do the circular knitting.
That's really interesting.
The machine will be in Germany, but they also be in China. So now our stockings are $25 compared to $100. Same, just because they're made in China and but still made on the same machine. So really, anyway,
it's quite interesting.
Yeah.
But the cost has come down hugely.
That's the end of the questions, Rebecca and Emil. So thank you so much. Lots of nice comments coming in, and I would like to just reassure people they will get their certification. That will come to you. The session is recorded and will be available. And please do just take a few moments to complete the evaluation, which you will see as you leave the meeting. Thank you very much for your attendance. And thank you all there at the Southern Wound Healing Group for all your hard work. It's been a very, very informative 2 evenings. Thank you so much.
Thank you.
Thank you very much. And thank you, New Zealand.
Thank you,
Have
guys.
a good night.
Thank you.
Thank you for your interest.
Good night.
Bye.
Bye.